Uh, Hello there. I think it's 1 o'clock, so we'll begin. My name is Alex Lowe, and I'm thrilled to be here with my colleagues, Dr. Shan W, Ula Hwang, and Chris Carpenter, all of whom are here in the front. This is the part where we talk about why we're here and why should you care, to put it bluntly. We are part of the Geriatric Emergency Medicine Academy, or AGEM. And aside from loving old people, we found that there is not a lot of evidence to drive the things we do. You may recall in 2014, we put out some geriatric guidelines. And now we are working on the second iteration of it. But what we are finding, not just in emergency medicine, but in many parts of medicine, is there's a need for transparency. There is also a need to put some evidence behind the guidelines that we have. So we have decided to undertake this huge process that is robust, for lack of a better word, but it's very driven by evidence. We think it helps not just our subspecialty. I think this is something that emergency medicine needs. But the reason we're here pitching this to you guys, and specifically we're trying to appeal to those of you outside of the geriatric emergency medicine environment, is because we went through this. We want to tell you how we did it and why we did it, but we really need to hear from all of you. What do you think about it? Is this something valuable to emergency medicine? Is this something valuable to your subspecialty? Because we're products of our environment, and how this works for you guys also affects how it works for us. The goal, of course, is to put out guidelines that are evidence-driven and transparent, but it takes a lot of work. So shortly, the four of us will take turns telling you how we did it. As we go through our talk, I would ask you to keep in mind the question, which is, could we, meaning whatever subspecialty you are, or if you're not a member of any subspecialty, is this something that I can see, A, working for my subspecialty, or working in a more widespread fashion for emergency medicine? And if not, it's important for us to know why not. The challenges you face, the problems you foresee, will help us make our work better, okay? So to begin with, Dr. Shan W.
Great. Thank you, Dr. Lowe. So thank you all for coming. And I'll be just talking about how this journey started with the Geriatric Guidelines 2.0. Just as far as disclosures, we have no conflicts of interest or other disclosures other than the funding listed below. We just want to acknowledge that the Geriatric Guidelines have great support from John A. Hartford and West Health, and that the speakers are also supported by such organizations and the NIA, EMF, and AHRQ. So the main question is, how did this all start? And really, it started over a cup of coffee. I was the incoming Academy of Geriatric Emergency Medicine president, and literally I was talking with Tony Rosen, who was the president, and Scott Dresden, who was also on the board, and we basically were having coffee at one of these meetings and said, you know what? The first guidelines were published in 2013, and what are we going to do about the second, rendition? And that's how this whole journey started, with those kind of beginnings. So that year, we decided we would actually bring it to the business meeting. So our Geriatric Emergency Medicine business meeting is every year at at SAEM. And so we brought it to the group, and we said, this is our journey. It'll probably be 7 or 8 years. By the time we get a product out, it'll probably be about 10 years after the first set of guidelines were created. So how do we want to move forward? And after that, we had a group of surprisingly, about 40 or 50 people coming on these Zoom calls because COVID was starting. But after that, basically 40 or so people would come and discuss what these guidelines meant and why would we do it. We invited people from the American Geriatric Society, from ACEP, and also from the Canadian emergency physicians groups. And so then there was a series of meetings on Zoom where Chris Carpenter, who will speak here, talked about the grade process and why we should be thinking about doing this, and why we as a specialty in emergency medicine and the geriatric group should really consider doing it with this evidence-based method. And then, like all emergency medicine groups, after 6 months of talking about it, people were like, we just want to start. We just want to do it instead of keep talking about it. So about 6 months later, in December, we decided we would just jump in. And our first topic that we tackled was delirium. We also did a survey, really just kind of surveying the entire group to say, like, what are the topics we want to cover? Should we do the grade guidelines? Should we do consensus, the consensus method? And since then, it's been now 3 years where we have large group meetings quarterly. And then we have 6 topics now that we've divided up into. And those groups meet either monthly or more than monthly. So there are other guidelines out there. The Silver Book 2 was published in the last 2 or 3 years, and this is a group from the UK that basically that's more consensus-based. So they do basically recommendations on the quality of urgent care for older people. The Geriatric EM group also published this, and these are like posters for, best evidence for various things like dementia, falls, delirium, and things like that. That's published by the European Society for Emergency Medicine and the European Geriatric Medicine Society. So that's another set of guidelines. But this is what we did. We basically, month 1, had a discussion of like, how do you define guidelines? Like, what are the guidelines that are being published by ACEP? Month 2 was the introduction to GRADE. Month 3 was the intro to the Guidelines International Network. So Dr. Carpenter will go into like how many other specialties really buy into this kind of methodology. And then in month 4, we went into rating the quality of guidelines. And month 5 was like, how do you get patient input into creating guidelines? And month 6 was, how are we going to update our guidelines and get this funded? So the main debate in all of these 6-month in these 6 months that we were debating was, what do we do grade or do we consensus? And our previous set of guidelines was largely consensus-based. And then the question that everyone had was, how are we going to do this? Like, what's the scope of the work? Which questions are we going to do? And how are we going to actually get people to do this? Because it does take a tremendous amount of effort. But ultimately, like I said before, we just put it to the group, which included about 50 people. And we said, well, after 6 months of debating it, learning more about it, learning what we'll have to do, let's just put it to a vote. And the group voted that we should actually pursue the grade method instead of just doing the consensus methods before. And then these were the ones that we ultimately decided to first look at, like falls, delirium, dementia, medication safety, and then now we're doing palliative care and frailty. So I will hand this off to Dr. Lowe to talk about mechanics.
I imagine many of you in the audience have been involved with creating guidelines, so the next few steps might be familiar to all of you. So how did we go about doing it? How did we recruit colleagues and friends? So the first part is get a diverse group of experts to come work with you. These are people you will work with often, so of course we thought about our colleagues, our friends. And it also was going to be a group that you wanted opposing opinions, different viewpoints, because I think it just enriches the whole thought process and all of that. So aside from ED physicians, we really wanted to make sure we had ED nurses, ED pharmacists, even our techs, paramedics, geriatricians, OT, PT. You may have heard a lot of the recent literature about PT, OT in the emergency department, helping older adults and not so old adults, social workers. And this is the part that we felt was really essential. We tried to find patient representatives or their caregivers, especially for those with dementia. It is tricky because you might think, well, how is the one patient or representative that we know going to be representative of all the patients out there? It has to start somewhere. So just getting a patient, it was eye-opening just to hear what a patient or caregiver thinks that we often take for granted. And then we now have this pool of a group of professional stakeholders, or not so professional stakeholders, as we call them, for the family. And because of the ask, or because of the amount of work and time and hours you'll put in, we thought it was best to have them self-select to topics that they would be passionate about. So we had decided from many other processes through narrative reviews, systematic reviews, Delphi methods, what are the big questions we wanted to answer. So we came up with a bunch of topics. For us, for this year, for this version of the guidelines, they are delirium, dementia, falls, frailty, palliative care, polypharmacy. We are even considering some other topics such as abuse. And then we said, hey, you can join one or more groups. And actually, a number of us are in several groups. We have program leaders, Dr. Carpenter, and Dr. Liu, and Dr. Hwang, who would oversee the entire process so that there's some uniformity, there's some common themes, common approaches, and to make sure it all comes together in one cohesive product at the end of it. And 1 or 2 senior faculty members would lead a group. So for example, I am one of the co-leaders of the dementia group. And then within that group, we made sure that we had diverse group members, diverse stakeholders. We've actively even tried to trade people, like say, hey, I think you'd be better for this group. How about you give us that person, we'll give you this person. Or maybe I wasn't supposed to reveal that, but we did that. And then, so, we got a pretty nice group going, and then we just try to meet whenever we have to just to get the process moving. So here is an example. I'm also part of the delirium group, not as a leader, but as a participant. And so within each group, then the next question is, we would like to be able to produce some guideline on some clinical topic. So within delirium, what are the priority topics? And there's a lot of work happening concurrently in parallel with the GEAR network that you may have heard of, and other experts within our subgroup that have come up with these questions. So we are guided by the literature. We're guided by consensus at this point to decide what are the big questions that we should prioritize on. So for example, with delirium, a common scenario that any emergency physician runs into is someone shows up in the ED, they're altered, and you say, I think it looks like delirium since it's sudden and it's waxing and waning. Do I need to get a CT? So this is something that we worked on for a while in our group, and coming up with a nice, reasonable PICO or research question that can be done. Now, at this point, I'd mentioned there are 2 philosophical approaches. A, should you look at the literature and decide what the question should be? Meaning, if you think that the question cannot be answered because there's not enough evidence, should you still pursue it? Or philosophy number 2 is, the question is clinically important. It is important enough that we should ask the question and then describe if there is literature or not, or evidence or not, to answer that question. Because if it's not, that still informs the community at large. This is where research should go into. And if it does, then what is the best evidence pointing to, right? So the question that we came up with is CT head useful for ED patients presenting with suspected delirium? And that's some work that we did. That's a paper we published recently. And the next step is where Dr. Carpenter will describe how we took that question and how we used it to make it a grade-driven approach to lead to guidelines. Oh, sorry, one more slide, I forgot. So the specific PICO question we had is, so is CT head useful for patients presenting with suspected delirium? And we wanted to, the statistic we wanted to offer is to report the proportion of older adults who presented who have acute abnormal findings on CT. That, in a way, answers the question, was a CT useful or not? So that's our PICO question, as you can see. Not all questions will come up with a nice, convenient PICO format, and you can modify it, reminding the audience that the PICO is a tool, it's not a rule that which we should be subservient to. Okay? All right, so now passing on to Dr. Carpenter.
So thanks all for attending today, and certainly if you have questions, I know people have to go to other meetings, please raise your hand and interrupt us along the way if you have something to say. My grand vision for this didactic as it was put together was that we could attract some of the academies and interest groups and expertise at SAEM to start to think about creating clinical practice guidelines for their area, written by emergency physicians for emergency physicians, things like emergency ultrasound, the Academy of Emergency Ultrasound, the Disaster Medicine Interest Group, the GEMA group, Global Emergency Medicine, The way that historically emergency medicine has looked at guidelines is that something for somebody else to develop, the American Heart Association, the American Cancer Society, and that ends up being others telling us how to practice emergency medicine. I think we're mature enough as a specialty. We're at that emergency medicine 3.0 stage now, the next generation of emergency medicine, where we can start to write our own practice guidelines. And I think taking a very scientific approach can have multiple wins for us, not only for our clinicians, but also for our educators and our future researchers, by convincing funders that there is a science to emergency medicine, and we understand what we know and what we don't know, and how to get closer to the truth of what we don't know. And so we're going to walk you through, my subsection is going to be what are guidelines, how do they differ maybe from the ACEP clinical policies that have existed for 30 years, and why this GRADE approach, which sounds pretty labor intensive, the way it was just described, how are we going to realistically do this in a feasible time frame. The GRADE approach says that you start with very answerable questions, which I'll walk you through in just a minute, but base the evidence on systematic reviews of direct evidence from that very focused question. And so that starts with a systematic review. The guidelines themselves are defined in different ways, but basically a structured way of looking at the evidence and synthesizing it in a way that our vast array of clinicians, educators, and healthcare policymakers can use, with actionable statements, and preferably rating the quality of the evidence in a way that is transparent so that everybody can understand where you came to the recommendation you did, the direction of the recommendation, and the strength of the recommendation in a very transparent way. So why create guidelines? Why not just allow our clinicians to practice the way they have since the early days of emergency medicine and just find the literature on their own, synthesize it, and adapt it into their practice the way that they feel appropriate? Anybody know how many publications there are every day on PubMed? If you were just to look at one day's worth of what's new on PubMed? About 5,000 new citations a day. So if you were to not sleep or eat or work, just divide 5,000 by 24 and you'll know how much you have to read per hour to be able to keep up with the literature. It's really an unwieldy task, and most of us aren't really up to date on everything all the time. The guidelines allow us to, with a group of experts in the field who this is what they do for a living, ultrasound or disaster medicine or whatever your niche area is, to really hone in on the practice-changing evidence and synthesize it in a way that our clinicians can use. That's why I think the guidelines have a real solid role. It also helps HRQ and NIH and CDC to understand where our specialty is right now. And particularly, you look at the guidelines for reasonable and acute care in emergency medicine. We've now got 3 of them: chest pain, abdominal pain, and dizziness. Dizziness just came out 6 days ago. The abdominal pain one is recurrent low-risk abdominal pain, and we found almost 0 evidence for abdominal pain. We see that every day, right? Probably 10 times a shift on an 8-hour shift. And a lot of these patients were here yesterday with the same abdominal pain were here last week. And we really don't know what's the role of CT. What's the role of an ultrasound after CT? Do the labs help us? Do they need to see a psychiatrist? Is this depression or anxiety? And we also don't know the inequities that are involved with that. Is it different if you're a male physician seeing a female with recurrent abdominal pain? Do you treat them differently? And so we need to make sure that we're looking at this evidence through the appropriate lenses. So I think guidelines allow you to do that in a way that the original research studies don't. They can also help you to illustrate some practice variability. This is from neurosurgery literature, because I used to teach our neurosurgeons at WashU about evidence-based medicine and guidelines. So I was showing them the role of guidelines in closing some of the practice variability gaps. And this neurosurgery research showed that most are aware of practice guidelines, and that it does tend to change some of their operative management strategies in terms of getting it to the right patients at the right time. Interestingly, we just did a study for ACEP clinical policies that we submitted to ACEP 23 as an abstract, and we found that a lot of emergency physicians aren't really aware that ACEP clinical policies exist. So this neurosurgery results may not completely be replicated in emergency medicine in 2023. There's also this information that shows that, again, in the neurosurgery world, that you may decrease mortality post-publication of clinical practice guidelines by synthesizing that information in a way that surgeons can use it and access it real time when they have those patients in front of them. So who's creating clinical practice guidelines in emergency medicine? I mentioned the ACEP clinical policies. Back in 1992, long before my time on the clinical policy committee. Rich, I don't think you were there either. That they decided they weren't going to make guidelines. They felt that that painted our clinicians into a corner in a court of law, and that guidelines were too restrictive. So they went by the name of clinical policies. The ACEP Clinical Policy Committee also decided they're going to develop their own system for how to rate the quality of the evidence, and how that rating then gave to the strength of recommendation and the direction of recommendations. There isn't anybody else that uses that system except ACEP, so it makes it hard for our neurosurgery and our orthopedic surgery colleagues, our cardiology colleagues to understand our rating system. It's not completely transparent, and nobody else is using it. So there's nobody really else producing clinical practice guidelines, with some exceptions. The Canadians have a couple. They've got one for AFib. I think they have one for ankle injuries as well, and vasopressors. And again, the ACEP clinical policies, there's a lot of those, and they are high quality. But again, they're not using a system that the rest of the guideline producing world is using. So we keep talking about grade, and what is grade? What are some of the mechanics that make grade what it is and how it's different? This illustration I'll spend a couple minutes on. It kind of walks you through the process of what grade is. And this is what we use for the SAEM GRACE process. So it starts with a panel. And that panel includes experts, people that have spent a lifetime thinking about a condition, like Jonathan Edlow and dizziness, and writing lots of papers, dozens of papers on this topic, educating generations of emergency physicians on the topic. So it includes those experts. It also includes methodologists, folks who have taken some extra grade training and understand what grade is. It also includes an independent panel of systematic review people, people that are experts in writing systematic reviews and aren't part of the guideline writing team, but help us to synthesize that direct evidence that we're going to use as the foundation for what we write for the clinical practice guidelines. We start that panel, once it's put together, formulating a PICO question. And the PICO question, if you've not done EBM stuff at Journal Club, it's the patient, the intervention, the control group, and the outcomes that you're looking at. But you don't stop there. You also rate the outcomes. So if we're looking at a fall study for geriatric emergency medicine, perhaps a recurrent fall is less important than death from that fall, or less important than decreased quality of life. And so our panel, including a patient representative, rates the importance of those outcomes, and then we choose, do we include all those outcomes, or are there some that are so unimportant that we're not going to base our guideline on those outcomes or even look at them? And then you do your direct evidence systematic review, and you put a summary of evidence table together, and you rate for each of the outcomes that you've now included the quality of the evidence, high, moderate, low, or very low. And then obviously a randomized control trial is considered the highest quality, but you can rate down based on risk of bias, inconsistency across the studies, indirectness, if the studies didn't occur in the ED, if it was like a falls clinic, imprecision, if the studies are all over the board, or publication bias. And you can rate up the quality of the recommendation, the strength of the recommendation, if you have a large effect size, a dose response that's recognizable, or if you have opposing biases or confounders that may be skewing the observed results. And then you formulate your recommendations based upon the evidence and the strength of evidence, and formulate your guideline recommendation in conjunction with something called the evidence to decision framework. And that's really where you spend a lot of your time, is putting that evidence to decision framework together. And that looks at several different facets of the evidence, including the quality of the evidence, the balance of benefits to harms, quantifying them as much as you can into number needed to treat, number needed to harm, in a way that multiple stakeholders can understand. The values and preferences of the panel, including the patients and the clinician stakeholders, the feasibility, the equity, and the acceptability of the recommendation, and then the resources to be used. And a lot of these things are really hard to measure. There's not been publications on a lot of equity considerations. Costs are almost non-existent if you're not talking about like a pill or a device. Those things don't exist. Like how much is it going to cost to educate 100% of the emergency medicine workforce in 2023 to do the HINTS exam and the standing algorithm for dizziness? Nobody knows. How do you even estimate that? So those are the types of things that we spend a lot of time trying to figure out. And then after that, you have your recommendations. And we try to report all those facets of the development in a transparent way, so anybody reading the document, the guideline recommendation, understands how we got to the recommendation we did, why the direction of the recommendation is in favor of or opposed to the intervention or the diagnostic test, and why the strength of the recommendation is the way it is. When you have that foundation of systematic reviews to build the guideline upon, it's a really sound foundation for the recommendation. So why grade? That sounds like an awful lot of work. That's years of work. Well, most organizations in the world who are creating guidelines now are using grade. They say they're using grade. If you really put it to a litmus test and look under a microscope, they're probably not adhering very well. Nobody's ever done that study. But they say they're using grade, and that's across nations. So other specialties can understand what we're talking about when we talk about the grade system that we're using. There's also been some research in the pediatric world that says clinicians prefer grade. The grade, as opposed to other methods, actually changes what they do. It's more likely that they'll accept the recommendation and use the recommendation in practice, at least by report. So we didn't do this with the first geriatric ED guidelines. This is a bit of a change. Ula's going to bring us up to speed on the history of these guidelines and how we can actually move forward with this grade approach across all your academies and interest groups, and certainly encourage your questions and comments. Thank you.
Chris, was that last slide that you had up, was that comparing clinicians' acceptance of grade-based guidelines versus consensus-based?
Compared to any other formulation. So consensus-based was the most common, but there's other, like AHA and ASAP use different formats. So it was comparing grade to anything else.
Okay, thanks everyone. So I'm going to actually shift gears a little bit and bring us back now towards the history, because you're all going, okay, this is amazing. The GED guidelines version 2.0 are moving forward using the grade approach. How did you get there? And it didn't happen overnight. And so I'm going to give you some of the context and history, especially for those of you in other content areas that might want to use this approach. And I will say it's a lot about understanding the history, but also the partnerships that have been built and where the guidelines can now move forward the field. Okay, so a lot of this was driven by the fact that in over a decade, 2 decades ago, there were no such things as geriatric emergency departments. But what we started to see, once the concept was out there, that hospitals began to sort of market that they were doing geriatric EDs. And Tess Hogan, in a snowball survey sample, identifying places that self-identified or self-designated themselves as being geriatric EDs, when they were forced to actually say what they were doing, there was a recognition that, oh, well, actually we're not doing any geriatric ED care. Maybe we aren't in fact geriatric EDs. And when we recognized this, many of us were like, oh my goodness, there's a lot happening where people are stating this, but they're not actually changing anything with the care that they're doing. And so that was the big driver behind the first round of geriatric ED guidelines. So it was really stripping away like the fact that, okay, if you're going to do this, then at minimum you should put forth some follow these recommendations of care. And when we found at that time was there was not a lot of evidence within emergency medicine, and a lot of it came from outpatient and inpatient care. It was a big organizational push. You'll see in a moment as I show you the history of many of our organizations like SAEM, AGS, the American Geriatric Society, ASAP, and ENA, Emergency Nurse Association, coming together to say, well, how do we advance the field and do this together? So this began even before this, though. There's been a big emphasis and a focus, and we're really showing this to show you that it didn't happen overnight. This has been going on for several decades. GSI stands for the Geriatric Specialists Initiative. When it comes to geriatrics, there will never be enough geriatricians in the world. The geriatricians recognized this and said, well, we need to bring geriatrics to our specialties and fields. And so emergency medicine was one of them. Hartford, Atlantic Philanthropies, other organizations really supported and moved this work forward. Fast forward a decade later, concepts of geriatric emergency care, AGEM, which actually at the time began as interest groups and task force work here at SAEM, Geriatric Emergency Medicine section at ASAP, those all continue to move forward. We saw the competencies. This was, again, consensus-based guidance around what residents needed to know when it came to geriatric patient care. Those started to come into place over a decade ago. And then the guidelines work really didn't start until 2011. So in those early years, again, I want to really highlight, this was a partnership of many organizations moving this work forward. And the guidelines were sort of endorsed. It was really a lit review, more of a very cursory lit review of what we could find in the evidence in outpatient and inpatient care, and then writing of those guidelines that were then endorsed by all 4 organizations in 2014. So think about that. That's like a decade ago almost. And then moving forward from there, the guidelines came out, but then well, how do hospitals and EDs implement this work? National organizations and hospitals came together with support of the John A. Hartford Foundation and West Health Institute to create the Geriatric ED Collaboratives. This is how hospitals can learn from each other in terms of the implementation of the guidelines work. And then very importantly, subsequent to that, we started to see ACEP piggybacked off of that. They built their Geriatric ED accreditation program off of the guidelines, right? This is now a big push on building off the work of the guidelines. Well, we're going to recognize hospitals that are doing this work in optimizing the care of older adults. And the NIA started to recognize the importance of this because we piped to them the importance of both guidelines are being driven, but there's no evidence. How do we move this work forward? And the NIA started to fund GEAR. It's like a geriatrics-focused version of PCARN, the Geriatric Emergency Care Applied Research Network. A decade later, 4 years later, additional organizations also recognized the GED guidelines, CAPE, the Canadian Association for Emergency Physicians, AAEM, the American College of Osteopathic Emergency Medicine also recognized the guidelines. And then we continued to grow the network of research around it, now focused on dementia care. So that was GEAR 2.0. And here we are. This is going forward. 2.0 is what you just heard earlier in the talk. The updates, because that evidence that was generated is almost a decade old now. And even ACEP this year have updated their Geriatric ED accreditation program to be even more rigorous. In order for them to keep that program sustained, they have to build it off of guidelines, and the guidelines are now being updated. So again, this big focus on updates and the importance of moving this work forward, but it's built off of a lot of work, and now they're taking a more rigorous one with GRADE. I just want to highlight, it wasn't just a couple of people. It was like a banding of many organizations. In the bold are all of the organizations that work together on this. Chris and I at the time were in leadership positions for our academies or sections, and we said, let's work together on this. You heard Shan talk about how she and Scott Dresden and Tony Rosen over coffee really said, well, we got to continue to move this forward and do version 2.0. So again, it's built off of a lot of collaborations and pulling together transdisciplinary experts. The guidelines, this is the initial version, they're still up on the websites for all of these organizations, and they publish the same guidelines. And so in summary, the things I really want to highlight, it's a lot of volunteer work, it's a lot of effort by the leaderships of those groups, but to conscientiously work together, inviting, it's a transdisciplinary effort to pull together and represent the people that are implementing this work and becoming the backbone of the accreditation program. This partnership and support is really critical, and again, without the partnership and support of organizations and also funders to move this work forward, it's very hard to advance. Question in the back.
Yeah, I love this work that's been done. I was just curious, having been trying to develop some of this myself, if you guys have looked early on or at least subsequently about other funders, including like AARP and others that might be interested in this space.
Great. So I'm going to repeat your question because we have to put it into the microphone. So the question was really, have we looked at other funders to support this transdisciplinary work and going forward? Is that correct? Okay, great. Yes, we are always looking for additional support. AARP is a good one. We haven't received any support from them when it comes to the guidelines effort, but they have started to recognize the importance of geriatric emergency department care. And as an example, AARP and the Alzheimer's Association, they've put together videos to really help disseminate materials, so information around how to optimize care for individuals when they come into the emergency department with dementia. But it's a really critical thing to look at and continuously evolving support and looking for additional partners. So now we're going to have Shan come and talk about the pros and cons of the approaches that you've heard.
Well, actually, we're going to also open it up and hear from you all about what you think about this, and if you would consider doing this in your specialty groups, or your subspecialty groups in emergency medicine, and really just, we can go over a little bit about the pros and cons from our standpoint, of what, when we were deciding as a group to go forward with this. But largely, do want to hear how you feel about it. So. Yeah. Dr. Edlow?
Jonathan Edlow from Boston. I would just like to make the comment, maybe the proposal, that because the grade method is so labor-intensive and involves so much time, that I don't know that it's an either-or proposition, that you couldn't have a few, grade-done guidelines, and then a handful or more of consensus-based ones that could be done much quicker and labeled differently. One's a guideline light. But it seems like you could just get more information out at a lower degree of evidence, doing it by consensus, and that you should consider doing both at the same time.
Yeah, that's a great point. And that ultimately I think there were about 36 to 40 recommendations in the original geriatric guidelines. And I think we said there's guidelines like you should have food 24 hours a day. And I said, we're just not going to have a whole grade question or PICO question about should you have food. And so, yes, we're going to tackle the big 6 or so areas of like delirium and falls, and then 2 or 3 PICO questions. So we'll probably have in the end 10 to 12 systematic reviews, and then at least 6 grade guideline documents, and then the rest will probably be things that will do more consensus, to your point, that I think the group, we have about 40 or so people that come consistently that are involved, but it is a labor of love, and it's hard for us to keep asking, various rounds of it. And I think when you get down to like the questions probably just don't have a lot of evidence at all about it, so it's not worth it to do even a systematic review. Yes, in the back, yeah?
John Balitz from Northwestern. I've done a lot of work in the ASAP ultrasound section, and as well as with the SAEM Academy for Emergency Ultrasound as well. And yeah, it's been interesting in emergency ultrasound as we've developed into a focused practice designation. Our guidelines have been traditionally just that, starting in 2001, then 2008, then 2016, and now another iteration is coming out. Generally just guidelines and consensus by recognized experts, but I think this idea is particularly intriguing. There may be some limitations in it, in that the majority of our studies, of course, around diagnostic accuracy and training, and it's a lot harder to really tease out outcomes with a diagnostic test. But I think this is very interesting and something that the current ASAP leadership and SAM leadership is interested in exploring.
Yeah, but you could very easily see that, if you want to have ultrasound in your department, the rigors of is everyone trained, and, are they following evidence-based guidelines and things like that, which is, exactly what happened with the first guideline, so that it led to accreditation across the United States. And now there's 450 geriatric emergency departments that are accredited, with ASAP.
I would encourage folks to look at the evidence decision frameworks for the GRACE documents. We've got 1, 2, and 3 now. At the bottom of those, there are research priorities we identified. So like you had just said, most of the studies are accuracy-based. So how would you design an ultrasound study that gets at some of the more centric, what we care about, the patient-centric outcomes? It also has implementation strategies. So how would we actually take these recommendations to every ED in the country and implement them? And it also has some subgroup considerations. Does this apply to men and women, to rural and urban settings? Is there an age difference? So a lot of those thought processes go into developing these as well. So I'd encourage you to look at those. And just for the funding question, we did have some conversations with the NIH. How do we get these funded? And the NIH is very clear at this point. We do not fund guideline development. That's the society level. They figure out how to fund those. HRQ does have some mechanisms in place to support pieces of this. They have I think it's a biannual call for systematic reviews. So you can put a systematic review proposal in, and if they accept that, I think they accept 2 per cycle, they'll do the systematic review for you in about a 6 to 8 month turnaround. So that would take the systematic review portion out of the equation. Problem is that that's a long time to wait for the systematic review, and there's no guarantee that your proposal will be accepted that cycle. And we're trying to keep this on a timeline. But there are some support mechanisms out there from the funding organizations.
I'm Evelyn Brady from West Health, but I'm wondering if there's any plan. Oh, yes.
Thank you. We love you.
I'm wondering if there's any current plan for the guidelines to try to inform ABEM's content for certification and recertification, if there's any hope that that can update the competencies.
Oh, do you want to answer? Since Chris is involved in that.
Sorry, that
No,
might be a
there's-
hard
there's
question.
no plans for that. I am the content editor for ABEM, my EM cert, so consciously trying to get geriatric content in there and obviously higher quality geriatric content, but there is no formal plan for that to link these guidelines with that effort, no.
Abel Wakai from the Royal College of Surgeons in Ireland. I just want to ask, there's a potential issue when you're using grades for guidelines, because Cochrane reviews also use grades to reach their conclusions. How do you deal with a Cochrane review that you find eligible for inclusion in your guideline recommendations, which has already done a grade sort of assessment of the evidence? Do you discard what they've already done, or do you make use of that information? So otherwise, you're using grade twice.
Yeah. So in terms of our systematic reviews, we're really just focusing on the emergency department, and the Cochrane isn't usually focusing just on studies that are looking at care in the emergency department, for one thing. And then as far as when we're including it in the grade in those documents, we haven't come across. We're trying to look at primary, papers to like help us with our grade guidelines, rather than like guidelines. To your point, that we're not using it twice.
For Grace, for a couple of the topics, we have done a systematic review of systematic reviews, trying to shortcut, but none of those were Cochrane reviews. The Cochrane reviews generally don't isolate their findings to emergency medicine-focused research. If they did, I think we could certainly use those, but they'd have to be updated to the time when we're publishing the guideline.
Hi, Shahryar Zatapchi from SUNY Downstate in New York. I guess the challenging aspect of these guidelines is how often can you update them? What is your plan about updating these? And also, is there a mechanism such as what we do for scoping systematic reviews that you go for if a high quality RCT pops up somewhere, can you include it in the guidelines and not wait for 5-7 years to update the guidelines?
So grade does have a checklist that you can fill out for when the guideline needs to be updated. We haven't gotten that far yet because we don't even have the first one out yet. But my plan would be, with the group's consensus, is that we use the grade checklist that gives you criteria for when it's time to update that guideline. On average, in clinical practice guidelines across all specialties, that's about once every 5 years. And the ACEP Clinical Policy Committee doesn't even do that. We only update about once every 10 to 12 years. But that's my plan, is to use that grade checklist so that we can have some objectivity to it.
I would add to that, I think that certainly one of the challenges with how often we can do it is how much work and time it takes to create these guidelines. And that's one of the things we're learning. And again, the experience we had over the last few years may have been skewed by COVID. But I would argue actually meeting by Zoom has made us more efficient in a way, easier to schedule and all of that. But it does take time. So I think having it every 5 years, depending on how big your group is, might be a bit challenging if you're part of, say, the resuscitation group, which is a bad example because they have the American Heart Association to guide their guidelines. But if you're in a subspecialty that has large numbers, then certainly with greater numbers, you could get the work done sooner.
So hi, I'm Mike Wilson from UAMS in Arkansas. My question is about the Institute of Medicine criteria on constructing clinical practice guidelines, of which grade is a piece, but just a sort of a very large, important piece. And in my own research in suicide, we looked at how suicide guidelines for the emergency department were put together using those Institute of Medicine criteria. And what we found is not only did people not use the sort of the grade criteria, they also didn't do a lot of the stuff that you would expect, like getting the right stakeholders to the table, making them sign financial conflicts of interest and things like that. So this may just be my ignorance with GRADE. Does GRADE do that, or do we need a larger framework to make sure that the other parts of the process are also rigorous and done well?
So I think from the geriatric standpoint, we've not really thought a lot about conflicts of interest and the stakeholders. We've tried to get applicable personnel to the table. So we have nursing involved. We have the patient representatives involved, mostly emergency physicians still. But for the conflicts of interest, I've done a little bit of research in this area. We actually had a poster presented at AGEM 2 years ago where we looked at grade recommendations for reporting conflicts of interest. And it's done poorly, like you said, across specialties. But we think that there's more conflicts of interest that are probably more important, like intellectual biases. And how do you measure those, and who determines that? At the GRACE level, what we do is we have mostly a financial conflict of interest statement that's filled out and then turned into the board of directors, SAEM board of directors. They make the determination if it's significant or not. If it is significant, it gets reported in the GRACE paper itself. They don't look at intellectual biases, though. I think we've got a lot of room to grow to understand conflicts of interest in general. And nobody's doing checks on that. So it's self-reported. And if it's self-reported, no conflicts, nobody double checks that. I have a question that's kind of pertaining to you. How do you see these the academies across SAEM, like the psychological emergencies interest group? How do we, if we can't get those interest groups and academies to develop their own clinical practice guidelines, how do we cross-pollinate so that when we have something pertinent at GRACE or the Geriatric ED guidelines, that we can pull expertise from your academies and interest groups? How do we make that cross-pollination happen? And that's for anybody here who's representing an academy or an interest group.
Sure, since you looked at me, is it fair, by the way, to ask questions of the audience? I don't know. So, I mean, I think this is an excellent, articulate statement of the problem. And at least in behavioral emergencies, which is kind of my field, we've left that to outside groups. And so we have groups of predominantly psychologists and psychiatrists who are smart people, but who don't work in the emergency department, largely creating these guidelines. And that kind of goes back to my question for you. See what I did there? Kind of turned the question back around to you.
Nice.
I think we need the right stakeholders and the right people at the table in order to make sure these guidelines are truly representative of our practice patterns. And the Institute of Medicine criteria do have a very nice checklist that accompany them, which I think GRADE would fit into nicely.
Yeah, great points.
Lucas had a question.
Yeah.
Hi, I'm Lucas, part of the GRACE team from Brazil. I think there is, actually I have a question about what do you guys think, instead of creating a huge umbrella guideline where you answer like multiple questions and it takes like 2 or 3 years to publish, versus doing one systematic review, creating a recommendation based on that, publish, and then do one per time. And that's what the BMJ rapid recommendation does. They pick one question, do a systematic review, publish, giving a recommendation. I think, in my opinion, would be a much more efficient way to get the information out, and maybe it's a good idea for the other academies to work on.
Yeah. So actually, we aren't doing one big document. We will, probably put all the recommendations into like a white paper at some point that we can put on like the GEM webpage. But we are publishing all the systematic reviews as we go along, and then the grade guidelines for like 2 PICO questions, and put those together. So we are trying to just publish as we go along. The guidelines, that document is different, but it's hopefully within a year or so as a separate publication, though. But yeah, to your point, to try not to like wait 5 years.
I think one idea that I think has been floated is to have this umbrella concept of Guidelines 2.0. And the reason we wanted to put it under one umbrella is because we had 1.0, so people were familiar to that. So we wanted to follow off that brand. But we can certainly do Guidelines 2.0 and start saying, okay, we'll release this first, and then another one from 2.0, another one. So it doesn't have to be like one single product. coming out at one time. I mean, that's certainly something we're still talking about, but we're still early enough at the stage that I think that can be an ongoing discussion.
What I'm trying to say is that, like, the grade, the whole
Sure.
grade rationale is that in order to create a recommendation, you need a systematic view.
Yep.
And, we know university medicine physicians who are doing systematic views all over the place, like the ultrasound group, for example. You see in academic medicine all the time, diagnostic accuracy of blah, blah, blah in ultrasound. Why we're not creating, recommendations based on those systematic views? I think that's a huge
Missed opportunity,
Yeah.
yes.
No, that's a good
Yeah.
So Lucas, this is a great question, and it was a question you had asked actually at the start of the, before we had the presentation, I didn't have a chance to answer. I do think this is an important consideration for the group. I will say, a lot of it goes back to also journals. So in this case, like, even if you look back at the first geriatric ED guidelines, they're not published anywhere. There's pieces written, these geriatric ED guidelines exist, go to the website and see where the guidelines are. But they're not actually published. And so what your recommendation is, though, each time a piece of evidence comes out, it should come out as a publication, because it's hard to find a journal who will be like, well, we'll wait for your whole series, or each one, and we'll publish each one. And so, like, I think it's also important for this audience to really help advocate that there's a need for these types of papers to be published, because it's also on the journals to move that forward. But it's a good consideration for round two. Once each bit of evidence and once each of the grade questions are answered and addressed, how is that summarized, and how does that information get out with Guidelines 2.0?
So I will take your question in a second, but just to point out, I realize it's at the end of it. So for those of you who have to leave, thank you so much for being here. We would be happy to stick around a little bit to answer your questions. We've left up the pros and cons up there, and just to bring your attention to it, the left-hand column, I think we all know and love, right? This is all the good things about writing science and putting it out there. The right-sided column is the one really that is the biggest deterrent, and that is there's a human cost to it in terms of our time, our salaries, and also the cost for grade. So for those of you thinking about this, I think it's just fair for us to bring that to your attention. So.
All right.
One last plug, the Academy for Geriatric Emergency Medicine is having their business meeting right now. It started at 1:30 and it goes until 5:30, and it's up on the 4th floor in the grand ballroom.
And the gentleman in the back, I'm happy to meet you out there to answer your questions, so you don't feel left out, but thank you.
Thank you, everyone.